Good morning, dear Chairman, dear colleagues. Today is a great day. It's election day at the Russian Academy of Sciences. All members must be present, no exception, but one. The Vice President of our Academy allowed me to be absent since the Academy is very, very important to be friends with our colleagues here in Pakistan. So please accept the warmest words of respect and congratulations with this well-organized meeting from the Russian Academy of Sciences. Let's talk about a very interesting topic from my point of view, skull opening and cranioplasty from ancient time to the present day. The interest to the ancient trepanation in Europe arose in 1865. Very famous anthropologist and doctor, French anthropologist Paul Bracas received a very interesting gift from Peru. It was Inca skull. He examined it carefully and came to conclusion that the patient survived after surgery. He was very surprised by this fact. Why? In the middle of 19th century, at the very best hospitals in Europe, the survival rate was very, very low. Why? What was the reason? Poor diagnostic, topical diagnostic, poor surgical technique, and infection. How could the primitive ancient medicine cope with all this problem without fancy toys, as we're told, and definitely in low resource environment? Together with the Institute of Anthropology and Archaeology of Russian Academy of Science in Siberian, we carried out special research in the south of Siberia. It's a very interesting place. There is Karamak. This place was populated about 1 million years ago by, it was Homo erectus. And Denisov's cave, it was populated 280,000 years ago. And recently, our archaeologists discovered a new species of human being, Denisov's man. It was published in Nature 2010. So in the slides you can see the skull with different trepanation. It was 8000 BC. And we just examined this skull. It was looked like drilling technique with dried animal bone, but no bone regeneration on CT scan. So it's easy died this patient just after surgery, or it was postmortem. But 2,500 years ago, there was very interesting culture in the South Altai region. It was Pazyryk culture. People of gold guarded by griffons. It was mentioned in a Greek poet 600 before Christ. So ancient Scythian left a huge necropolis in Altai area and smaller one, as you can see, not discovered yet. And we examined 153 skulls from 36 necropolis and found very interesting artifacts. We examined them with skull inspection and examination and the magnification. Then we used multi-slice CT scan. We used MRI, 1.5 Tesla MRI scan, and very sophisticated special technology, coupled plasma mass spectrometry and synchrotron radiation-induced X-ray fluorescence analysis of skull samples at trepanation site and in the distance. Look at this skull. It was this trepanation was made 500 before Christ. We can see no bone fracture. Trepanation window just above the motor area, and the area is 3.5 centimeters. Very fine cutting technique. And we just scan it, and we can see there was very nice regeneration, complete healing. Patient survived surgery, and the patient passed over at the age about 60. Scythian could have used flint, iron, copper, or bronze tools for trepanation. They knew all this stuff, all these materials. MRI scan did not reveal the presence of ferromagnetic, but this sophisticated technology like mass spectrometry and fluorescence analysis demonstrated copper and tin abundance and the size of trepanation. So our ancient ancestors used, ancient healers used bronze. We just try to repeat their experience with the bronze knives, with drilling, scraping technique. And I can tell you, it's me, and I can tell you that it takes about 15 minutes to open the skull by tinned bronze knife without damaging dura. With training, you can do it quite easily and very fast. But why bronze? It looks like our ancient healers used antiseptic surgery with bronze tools. Because we never discovered any signs of infection, and I can tell you that the survival rate after ancient trepanation was up to 90%. Look, at the middle of 19th century in France, it was only 10, and before it was 90%. Recent research had established the strong bactericidal properties even against the MRSA of copper ions. Copper kills all germs. Maybe it's one of the secrets of their success. Look at this very interesting skull. We can see a linear fracture to the sinus, temporal and parietal bone, and it looks like a battle wound. Trepanation about 5 centimeters in diameter, directly at the fracture line of in the skull, and deviation from the sinus is about 1.2 centimeters. Very fine cutting technique. I would say I would do the same now with all our computers and high-speed drills to save the patient's life. We just scanned this skull and could see that there was very nice regeneration, complete healing, so patient survived surgery. And it was 2,500 years ago. But as the first scientist, I think, who started to talk about the artificial intelligence in America, Edmund Berkeley, one day told, very few problems have just one solution. Now we have got certainly another solution to skull opening. With all our computers in theaters, we use easy high-speed drills or ultrasound. I like very much to use ultrasound with very tiny, thin cutting of the bone, particularly in the pediatric practice. But a few years ago, we published in World Neurosurgery, our article about Scythian trepanation, and we just mentioned that in the area of methicillin-resistant Staphylococcus aureus, it may be useful to consider some ancient surgical techniques to use in our present practice. Now about cranioplasty. From antiquity to the present day. You have just listened very interesting lecture of consensus in our World Federation of Neurosurgery. But I just would like to look through the history of the development of the technologies. According to the literature, it looks like the first cranioplasty was made 2000 years before Christ. Because a thin plate of gold covering the left arrowhead cranial defect was found in Peru. Then we know that authors from ancient Asia, Egypt, Greece, and Rome, they used trepanation widely with considerable experience, but they had very little to say about the practice of cranioplasty. They directed more attention to the different kind of dressing applied to the top of the exposed meninges, exposed to the wound. It looks like the first trepanation, again, according to the literature, was not trepanation, cranioplasty, was made in 1668. And it was a nobleman in Moscow named Butterlin, who had received a sword wound to the head, and cranial defect was repaired with the section of the cranium of his own dog. And he survived this trepanation, and he was very fine. But Russian Orthodox Church excommunicated this gentleman for his blasphemy. Then we know a lot of literature about autograft. Mason started reimplantation of bone pieces into the cranial defect. Then appeared a Müller-Kinning procedure with scalp. Other autograft, scapula, sternum, ribs, despite of, so to say, washboard effect. Sternum was reported. And then allograft. Sickert, at the beginning of 20th century, reported on cranioplasty with cadaver skull. However, the general neurosurgical opinion had treated allograft with less favor and preferred bone substitutes or autograft. Xenograft. Again, in the end of 19th and beginning of 20th century, bone of different animals, not only dogs, like for Russian noblemen, but apes, goose, rabbit, calves, eagle has been transplanted into man. There were no restrictions like now, and everybody could use everything. Babcock reported his soup bowl cranioplasty, just he collected the bones from the hospital soup kettle and used it for his patients. Then a lot of attempts to use different kind of metallic bone substitute. Look at this. I talk about neurosurgery, we used aluminium, but unfortunately failed because the aluminium was the caused irritation to the surrounding tissue and disintegrated after implantation. Gold was very nice, but quite soft and very expensive. But at the beginning of 20th century, was reported about 100 cases. It was published. Silver also was used, But silver oxide reacted with this surrounding tissue, and it was not good for cranioplasty. Look at this, even lead was used to implant into the human being. But certainly they failed because it was very toxic and the implant was removed. Platinum was also used, too expensive. Then a lot of substitute from different metals like vitalium, zirconium, tantalum, and stainless steel. Then non-metallic bone substitute, celluloid, hard rubber, plaster of Paris, gum cork, polyethylene, and silicone rubber. What is our our current practice at the present time? Look at this, depressed fracture, and we just reconstruct of depressed fracture. We try to preserve the patient's own bone whenever possible. It is the best. It's not impossible in every case, but we try to do it. Titanium. We widely use titanium now, definitely. Titanium was first used for cranioplasty in 1965 by Simpson. This material has got some advantage. It's very nice biocompatibility, strength, low risk become infected. There is just one drawback, is difficulty to shape intraoperatively. But new technologies, for instance, the result of three-dimensional computer tomography performed preoperatively, can be used to manufacture a corresponding plate with excellent result, and it saves a great deal of time at surgery. There are two technologies we use to modify, to produce, to manufacture the plate for cranioplasty from titanium. One of them, direct metal laser sintering, and another forged stereolithographic implants. In the slide, you can see a forged titanium implant. It's from Burdenko Neurosurgical Institute, Moscow. But in our practice, we widely use direct metal laser sintering. And you can see here the result of cranioplasty in different cases, even in quite elderly patients. But it's not what trauma, it was tumor removal. And another material we widely use in our clinics, methyl methacrylate. This stuff was discovered in 1939 and was extensively studied in the beginning of 40s and had good strength, heat resistance, and now with barium impregnation, we widely use it in our practice, like in this small defect, but nevertheless we covered it with Palacost plus Craniofix. Another material is quite nice for cranioplasty. It's polyester ketone, PEEK. Look at this example, but it's quite expensive, I can tell you. And at last but not the least, hydrohypatite is a calcium phosphate compound naturally found as a mineral in bone and teeth. It looks very promising, and custom bone is a current, looks like ideal solution for cranioplasty. The customized implant is made of unique geomimetic ceramic materials that acts like bone when implanted. I like it very much, but unfortunately there is one drawback. It's very, very expensive. There was published in the literature the experience on 1,500 patients, and it was demonstrated that this material is very safe, very effective material, well tolerated in both adults and pediatric patients, and I'm going to demonstrate you this. Another choice, another option, bone replacement by splitting the cranium. This slide from Burdenko Neurosurgical Institute, we stopped using this technology in our practice, in our clinics. Why? Because of very high resorption, and you have just heard about this 20% resorption. It was published after neurochirurgic, and it's very expensive for hospitals to use this technology. Look at this. This young boy, 7 years of age, was operated abroad in Germany by a very experienced neurosurgeon. I quite well with the neurosurgeon. He's very nice. But nevertheless, 4 months later, we can see bone resorption. And what we can do for this patient, we use custom bone cranioplasty. And now 3 years later, no resorption, and he's doing very well. And if we talk about adult practice, custom bone cranioplasty widely used in adult practice, like this one gentleman after head injury. It was some kind of decompression craniotomy in one of the hospital in the far east of our country, and he was admitted to our clinic. You can see this material at operation and cranioplasty X-ray after surgery. Another case, this gentleman from Australia underwent very severe, craniotomy and decompression craniotomy due to his raised ICP. And he survived and he recovered quite nicely, and we performed again custom bone, and you can see quite nice cosmetically, and he's doing very well now. He's business coach and he enjoys his life now in Australia. So conclusion. The diversity of techniques proposed for cranium trephination and reconstruction from prehistory to modern medicine attest to the engaging nature of the topic discussed. The current technology made skull open in fast and safe procedures, but I would think we should not forget the experience of our ancient ancestors. And the implant of the future will provide immediate protection to the cranium, be aesthetically perfect, and be both osteoconductive and osteoproductive, and not too expensive. Thank you very much for your attention.